understand this is the last talk of this day. Half of my target audience is in outside having dinner, enjoying drinks. So let's see. I want to have a at least a laugh out of you at the behest of our anesthesia colleagues. I'll try to do that. Let's see how successful I get. So I'm Dr. Gourish Shinde. I'm the Anaesthetist in CathLab. So I went personally from this to this, from one console of sorts to the other console. Over a period of time, I've been doing only CathLab, exclusively CathLab work for last 7 years. And this progression happened over those many years. There is a story behind it, but that is for later. We have short of time. But what I mean to tell you regarding this is the anesthetist in OR and an anesthetist in CathLab are two different animals. An anesthetist in OR is trained to be relegated to the head end of the patient. They are trained to be, at the head end, managing things, then just sitting there once their work is done, and at the end of the show, extubating the patients and getting things done and shifting the patient to ICUs or recovery rooms. So I got this photo I pulled this out of some random web page, but here you can see the anesthetist being grumpy as well. So the thing is, that's how they are. And they will have hours of boredom, minutes of thrill during their work, and then sometimes seconds of terror. That usually encompasses what broad anesthesia work that happens in the OR. You plug this anesthetist out of an OR and put them in this cath lab, they will not know the heads and tails of it. The issue being, firstly, they will try to get a chair to sit in. And not finding one, they will sit in the console. So this is very intimidating space for any anesthetist because there are too many things going on in a cath lab, and in a very dynamic way, they don't understand things. Partly anesthetists are to be faulted for this, partly the cardiology colleagues, but majorly the fault lies with the anesthetist because during their training they are not apportioned much work in the cath lab. So what happens at the end of it is they will usually find themselves in some cozy place that is usually the console, out from action, away from action. And what I've come to know is that you don't have one station here. An anesthetist works best in the cath lab when there are multiple stations. My work over a period of time has progressed from station 1 to all these stations. For simplicity purposes, let's call them bases. Like a baseball court, this is a baseball diamond for me. I work in this, however messy this cath labs may look, it is my home for the major part of the day. 70 to 80% of my time I spend in this place. The arrows point to my routine workflow, whereas the numbers indicate the progression of my role in the cath lab. For base 1, this is the base that I start in. This is what I do on a regular basis. I sedate the patients, I manage the airways, and I take ultrasound guided femoral and difficult radial punctures in this situation. So this is me doing a USG guided access. This I do quite routinely. All elective patients, femorals are USG guided, 100% of them. All elective as well as emergency cases in my cath lab are sedated. Even for primary plasties, 90 to 95% of primary plasties, they give you that comfort that you can sedate them. Hemodynamically, they will require some inotropic support, but majorly they are well with sedation. And believe me, the procedure goes on very smoothly for the operator as well as the anesthetist if the patient is sedated. So I would like to touch upon slightly upon the sedation part. The sedation practices have no precedence in cath lab because anesthesia, usually anesthetists are comfortable with airway being completely secured or totally awake patient. There is no in between. Anesthesia will not like sedation in any respect. And in a particular situation like cath lab where they don't have IV access very proximate to them, and the airway access not very proximate to them, it's a challenge for them. So hesitation from anesthetists is from anesthesia perspective that the access to the patient is restricted. Hesitation from cardiologist perspective is that usually during training, cardiologists are trained with awake patients. So they would like to carry on with that perspective in their routine practice. As sedation has given me and my operator quite comfort in that it has afforded quicker turnaround times. The operator can focus in his work better, and overall the hemodynamics are smooth, better managed. With slight inotropic support, I can get by doing what I do on a regular basis. So sedation, what and how, that is a entirety of a different lecture, but I would like to touch upon it. I usually play around these three areas. I usually go around mild anxiolysis for my routine angiographies before they turn into elective plasties, or moderate sedation for all elective plasties, deep sedation sometimes in very cranky patients or in patients who are going for pacemakers where surgical incision has to be put in. General anesthesia, I generally avoid. So conscious sedation is something that I do on a regular basis and dexmedetomidine is a drug that affords me that comfort that I can do it day in and day out because it can be repeated easily. There is low hemodynamic compromise with it, and there is easy awakening as well. So it's kind of, if you with light stimulus you can actually awaken the patient, make them whatever you want to get done, and they fall back to sleep again. And it adjuvants well with benzodiazepines and opioids, reducing their doses as well. So advantages of these things are that you have reduced pain and anxiety. Given a choice, mostly all patients will prefer sedation. That is what is offered on a regular basis by me in the cath lab. Tolerability of transradial procedures is improved. Procedural comfort for patient and cardiologist. This is a very important thing that I have noted, that the cardiologist is much more focused on his or her own work when the patient is sedated, and he does not have to look up to the pain part of it. The radial spasms are avoided, and of course, there are some disadvantages, but I think a good anesthetist can get by managing them. In OSA patients, in morbidly obese patients, you have very noisy airways that can be done, that can be managed with a nasopharyngeal airway. Some maneuvering is required during stent positioning in these patients because you have a thorax which is moving too much. So usually I try to awaken these patients, or I will put in an airway so that at least the noisy part will go away. And the last point being the regular use of inotropic infusion. Now this, you can say it's a disadvantage, but for me it's not, really not, because I will get a smoother hemodynamic management with that. So regularly I am using for all patients inotropic support. Very minimal, but yeah, I do that. Moving on to base 2, this is where I do my subclavian guided access. This is me doing guided access in pacemaker implantations. This is quite a regular feature. Over a period of time, I've become very comfortable with this. And of course, as a procedural echocardiographer, I'm trained to, get on with my things during mitra clips and tears in general. I do handle rota consoles if the tech support is not available. So that is something that I've grown into. And of course, for emergency mitigation, for CPRs, for defibrillation management, I do that. Moving on to base 3, I handle the OCT and IVAS console. Handle the pacemaker. This is me fiddling around with my Ultron 2. And I saw a double up as cath technician in emergencies because being in cath lab for so long has afforded me some familiarity with the hardware that is used. Moving on to base 4, this is, I think, the most important base because I come directly from base 1 to base 4 for hemodynamic monitoring. So my cardiologist has outsourced this screen to me, and this is what I do on a regular basis after I've done sedating the patient and taking over the IV procedural access. Of course, I go on to become Man Friday in emergencies, when mostly in primary angioplasties in remote places where the scrub nurse is not available, I double up even as the second operator or the assist operator. So this is my routine workflow. I receive the patient in the cath lab, make them comfortable, offer sedation if it's a routine angiography, SOS plasty. Then I scrub up, get the USG guided access, hand it over to the operator. Then I flit in between the base 3 and 4 during my coasting phase. That is during when the patient is sedated and the procedure is ongoing. Very rarely I will position myself on the base 2, that is during the transesophageal echocardiography. And that's about it. In conclusion, the number of procedures and their complexity has increased, but the role has expanded and training needs to catch up. Anesthesia departments should incorporate training, I think. During their training phases, anesthesia should be more and more exposed to cath labs, and this might change the mutual perspectives that are held by both anesthetists as well as cardiologists in their respective fields. This is most important slide, I think. Yeah, this is how you, if you want your anesthetist to be, he or she should be besides you, not outside. If there one aspires to be a Tendulkar, there has to be a Sehwag to it. Thank you.